Good afternoon, everyone. Thank you for joining. Today we are hosting a webinar on COVID-19 and spinal muscular atrophy. I am Dr. Mary Schroth, Chief Medical Officer at Cure SMA. We are pleased to have with us today 4 healthcare professionals who will talk about their experience with the SMA community and how to manage the patient population considering the current global pandemic. We were happy to see several questions submitted in advance of this webinar, and we hope that many of these questions will be answered as part of the presentation or during the designated Q&A session later in the call. You can also submit questions during the call using the chat box in the bottom right-hand side of the screen. Lines will remain muted throughout the call, other than for Cure SMA staff and our invited speakers. If there are additional questions after the presentation and Q&A, please share them as part of your follow-up survey or by emailing us at webinar@curesma.org. I will begin with an overview, and then our 4 speakers will share with you insights into their experience. Go back, please. Caring for patients with SMA while also managing COVID-19. We are so pleased to welcome Dr. Bakri El-Sheikh, Becky Hurst-Davis, Dr. Richard Kravitz, and Dr. Robert Graham. Next slide. The U.S. now leads the world in the number of cases of COVID-19 in a single country. Transmission rate of every 1 person infecting at least 2 others. You are all receiving daily updates on policy, strategy, and what is projected to come. Briefly, everyone is familiar with the typical symptoms of COVID-19, including fever, cough, and shortness of breath. GI symptoms have also been reported, including GI upset and diarrhea. Of interest are the symptoms that may be associated with mild disease, including sudden loss of taste and smell that persists throughout the illness. Plus, there's a very large number of people without symptoms. Next slide. I want to share with you Cure SMA's priorities. The health, safety, and well-being of the SMA community is of utmost importance. We also strive to provide accurate and timely information to the entire SMA community. Next slide. We have created a web page for COVID-19 resources for the SMA community. I encourage you to look at this website, look at the materials that we have available. If there are additional materials that you would like to see, please email us at info@curesma.org. I also encourage you to review your professional society or association website for COVID-related information. For example, the American Physical Therapy Association has guidance regarding practice, and they also list payers that support telehealth for physical therapy care. Next slide. Just so that everyone is on the same page, I want to share with you the recommendations that we're providing to the SMA community. We're encouraging everyone to follow the usual SMA infection control and isolation practices and the guidances from the CDC. We are sharing with families that social distancing may need to be longer than the general population, and we've provided documents on the webpage that I referenced earlier to help support requests for extending social distancing or extending the time in isolation away from work and or school. We recommend that no one assume special immunity to COVID-19 and also to assume potential high risk for pulmonary complications. At this time, there just is not enough information about the impact of COVID-19 on spinal muscular atrophy, and caution is recommended. To do our part to facilitate and support social distancing, we've canceled our community events and other activities through May, and we're evaluating our conference and whether that should be held. Next slide. One of the questions that is frequent in the SMA community from both healthcare providers as well as from the patient and family community are the SMA treatments. It is our position that it's very important to give the SMA treatments on time as possible, understanding the risks within that community. SMA treatments are essential treatments. They're not elective. For those starting treatment, we know that the sooner treatment is started, the better the outcomes. We're also hearing that many families who have maintained health are very concerned about going into a medical facility. So anything that you can do at your facility to ensure safety and minimize risk to infection will be very helpful. Often this is requires pre-planning, and you will hear more about this from our speakers. In addition, I want to share with you that risdiplam, which is before the FDA for review, and a decision regarding approval was expected in May. That decision has been delayed based on additional clinical trial information that has been made available. Again, risdiplam, the decision has been delayed until August, and you can see the press release that is available through Genentech. Next slide. I also want to share with you that Cure SMA has been very active advocating for the SMA community. We are monitoring federal legislation such as the CARES Act for impact on the SMA community and ways that we can be supportive. We've advocated to state programs, state Medicaid programs, which have access to additional funding, and we're requesting that they expand access to services as well as supplies. You can see these documents again on the webpage that I cited earlier. Next slide. Cure SMA has also developed additional and new family support programs in response to the COVID pandemic. These available to families to address the current and urgent needs include the documents that are available on the website. We have a COVID-19 support package that families can request online, and this will include things like antibacterial wipes, masks, and things that people are requesting during this time. It's similar to the sort of support packages that we provide for newly diagnosed families and also for our adults. We will also be offering gift cards soon. We're also using more virtual meetings to maintain the community, including community webinars. We're holding a newly diagnosed family webinar next week, this webinar for healthcare providers. We will also be offering hangouts and chats for families so that they can continue to maintain contact. One other thing that I want to share with folks is that we have a newborn screening portal that is available through curesma.org/NBSR. And babies that are identified through newborn screening, we request that they go into that portal and participate in providing information. We also recently released the community survey, which is available on our website, and ask that the SMA community continue to provide us with information. We ask for your help in sharing this and encouraging your patients to participate in the surveys that we have available. Next slide. I am pleased to introduce to you Dr. Bakri Al-Sheikh. He is an associate professor, Department of Neurology at The Ohio State University, Wexner Medical Center. Thank you, Dr. Al-Sheikh.
Thank you, Mary, for having me. It's really my great pleasure to be here. Next slide, please. The new reality during the COVID-19 emergency truly impacted access of SMA patients to the multidisciplinary care team. As you know, a multidisciplinary care is the key element in the management of SMA patients. Fortunately, several tools became more readily available to help us deliver such care. For example, telehealth, including both telephone and video visits, can be conducted by the different team members based on need. After evaluating benefits and risk, if an in-person care is a must, it's important to find ways to avoid unnecessary risk of exposure. We found that pre-registration and phone calls prior to the visit to screen for the COVID-19 related symptoms and to share expectations helpful. For instance, most institutes implemented policies that limit the number of people who can accompany patients into the buildings. In addition, one can consider rearrangement of the routine visit procedures to minimize contact with other patients and staff as well, and allow direct entry from the into the procedure room or the clinic room. Next slide, please. Several new regulations for care delivery went into effect recently. The CMS issued a COVID-19 emergency declaration that helped loosen the regulatory rules. As an example, it provided contractors with more flexibility to waive replacement requirements for durable medical equipment, such that face-to-face requirement, new physician order, or new medical necessity documentation are not required. Another example is temporary waive of the requirement that out-of-state providers be licensed in the state. This applies to both Medicare and Medicaid. However, it is pertinent to check on each state policies as they tend to have additional regulations for telemedicine visits. Some private payers are following the CMS guidance. Nevertheless, it is important to check on changes for each payer and patient plan coverage. I listed a couple of documents that I found helpful. The document from the Medicare as well as the American Academy of Neurology on telemedicine and COVID-19 implementation guidance. There are few specifics with regard to documentation and billing, and it's probably best to consider sharing and discussing these resources with compliance and coding teams in your institute. Next slide, please. So as we know, FDA approved gene-modifying treatment with intrathecal nusinersen or Spinraza as a treatment for all individuals with SMA of all ages, and also approved gene replacement therapy with intravenous treatment with Zolgensma for children under the age of 2. As Mary mentioned earlier, these treatments are considered essential, and thus receiving treatment on time is the real goal. Majority of institutes in the US continue to offer these treatments on regular basis. However, there are certain situations where treatment delay may become inevitable. A few weeks delay in this situation, and this is more particular to the nusinersen treatment. So a few weeks delay is probably acceptable and not expected to have a major impact. We call patients ahead of time to make sure they understand the risk and benefit, and they have a good idea of what the procedures are going to be. And again, taking some extra measures so that we can move the patients from the entrance of the building to the procedure room with minimal exposure. The CDC has issued some guidance for people who are at high risk of complications or susceptibility to develop the COVID-19. So there is some evidence that shown that people with underlying health condition may be at a greater risk of serious illness from COVID-19. Thus, in general, the individuals with SMA are considered to be at a higher risk. So, similar to the clinical care, research activities were also impacted by the COVID-19 pandemic. FDA and institutions provided some guidance based on balancing potential benefits and harms to help investigators and participants to determine suitability for an in-person research visit. And also loosening the rules and allowing televisits to be used when possible. So thank you. I will go back to Mary.
Thank you, Dr. Al-Sheikh. My next speaker that I'm also very pleased to introduce is Becky Hurst-Davis. She's a clinical nutrition manager at Intermountain Healthcare in Salt Lake City. Becky?
Hi, thank you, Mary. I'm very happy to be here today to talk about nutrition and my recommendations for people with SMA. So next slide. In my nutrition recommendations for people with SMA, the calories are very highly variable on the severity of SMA for the patient. And the amount of lean muscle, as well as considering other factors as physical activity, nutrition status, and work of breathing. The best way to really know the calorie needs of somebody with SMA is to do indirect calorimetry. However, that is something that not a lot of institutions have or have the time to do. So instead, what I most commonly do is I will use an equation, either a standard equation or a starting point, and from that point I will determine an estimated calorie needs. So right now we'll use for kids, we'll use the WHO or the Schofield equation, and then we will without an activity factor for our basis of needs. We also have other ways for people to determine calorie needs. Another rule of thumb that I like to use for my patients who are non-ambulatory is to do about 7 to 9 kcals per centimeter height, and that is for people who are more severe in their SMA symptoms. People who are less severe, we can go from 9 to 14 kcals per centimeter height. The trick being that you need an accurate height measure. What we'll take is when we do estimated needs from just the RDA or a typical equation, sometimes our patients will require less than the typical estimated needs for somebody without SMA. So in general, I like to think, if you're looking at an estimated need of an infant of about 120, it's probably going to be 60 to 80% of that for somebody who has more severe symptoms of SMA. But we've also seen people who are hypermetabolic, so you really just need to take an initial stab at it using the equations that you have available to you that your facility uses, and then just monitoring growth or for children or weight maintenance for adults. What we look for typical protein needs, we look for about 1 to about 2.2 grams of protein per kilogram of body weight. For younger kids and infants, that can even go up to 2.5 grams per kilogram for protein needs, and that's just typical protein needs. Fluid, what we look for is for people with SMA to at least have their maintenance fluid needs. If you need equations to help evaluate that, we use Holiday Seeger for infants. We also use RDA. What we have to really keep in mind when we're determining fluid needs is if there are additional losses. For example, if you're doing a lot of respiratory treatments, there's a lot of fluid being lost through those losses for the treatments. You also, if a lot of people will have increased sweating with SMA, specifically, not even with illness, and have losses that way. So what we look for is at least maintenance, and in some cases you may need quite a bit more than that. What we look at for younger kids and infants, we look at the needs as being about 100 to 135 mils of fluid per kilogram of body weight. Next slide, please. when we're looking at illness with someone with SMA, we have several things that we want to make sure that we look at. One is to avoid prolonged fasting during illness. The length of time that you can be fasting during illness really depends upon the severity of SMA and and your nutritional status before you were ill. In general, if I have a patient with SMA who is on continuous tube feedings, then my general rule of thumb is I don't like them to go for much longer than 4 to 6 hours without nutrition if they're continuous feeding. Now, if you're able to eat regularly, meal times orally, and you're not as advanced SMA, you may be able to go longer. We did do a study where people who were well with SMA type 2 were able to fast for about, kids were able to fast for about 20 hours, but that was during well time. So what we really look at is for during ill time, we look at anywhere from 4 to 12 hours as our guidance, and the lower end for people needing more continuous feeds, the higher end for people who have a better nutritional status. What I generally recommend for illnesses, if you're not in the hospital, is if the person with SMA doesn't feel like eating, to recommend a clear supplement drink or a supplement drink containing protein to help give them what they need. The clear supplement drinks don't have a lot of fat, so if there's GI distress or discomfort, sometimes that's a little bit easier to go down. If we go for a long period of time for people who are orally feeding and they're not able to tolerate food, in those cases you may want to consider a feeding tube. And I'll go into that a little bit in the next slide. But for right now, like I had said in my previous slide, increased respiratory losses, as well as if we're having a fever, you really need to keep on top of the fluid. What they're seeing for people with COVID in the initial phases, that the dietitians I'm talking with are saying that adequate fluid is a real concern. So make sure you keep your oral rehydration solution on hand. If the person is experiencing GI issues, I do recommend limiting high sugar or diet beverages, as that can increase diarrhea. When people are ill with SMA and they're already on a home formula regimen, sometimes what we find is formula intolerance. In those cases, we want to dilute the formula with a rehydration solution for a short period of time. Sometimes if the person is on bolus, we may need to slow that down to longer and more continuous feeds. Sometimes we need to go from our standard formula to a more broken down formula. And then if we have a period of time where formula is not tolerated, we strongly consider parenteral nutrition. And then when we're in the hospital, we also monitor electrolytes and glucose. Next slide, I'll go over this. There are Aspen and the Society of Critical Care Medicine have come out with some nutrition guidelines. You can find them on the Aspen website if you want to read further. This is based mainly on adults and not persons with SMA. They do recommend that placement of a nasogastric tube with early enteral nutrition within 24 hours of admittance to the ICU or within 12 hours of intubation for patients. I want to just kind of put in my considerations in blue, which is the decision to place an NG tube was mostly based on the amount of aerosolizing of the COVID-19 into the air, as well as prolonged exposure to healthcare practitioners. With SMA, if there are aspiration concerns, you may need a nasojejunal tube in those circumstances. They're also recommending a standard high-protein tube feeding formula, so greater than 20% of the calories from protein. What I would consider for persons with SMA is to start with their home feeds on enteral nutrition. Sometimes with illness, you'll need a less fiber-containing formula, or you may need a more hydrolyzed formula than your typical formula. What they're advising is that they start with trophic enteral feeds and slowly advance up to 70 to 80% of the estimated feeding needs. And just back to my original slide, keep in mind that some people with SMA have lower initial estimated needs when you're making this consideration, as well as continuous feeds are generally better tolerated than bolus feeds, and this is something that we have seen true with our patients with SMA. Again, give parenteral nutrition early if enteral nutrition is not tolerated, and also to consider parenteral nutrition sooner if there are GI-related COVID symptoms. And this is no different than what I would normally recommend for somebody with SMA who's unable to tolerate enteral feeds. Within my hospital, system, if we're unable to get one of our more severe patients with SMA who's on a continuous feed normally, if we're not able to get them up to their feeds within anywhere from 4 to 12 hours, we will start parenteral nutrition for those patients. And I just also want to say that back to the timing of the feeds, I feel like for someone with SMA, 24 hours to wait before enteral nutrition is probably too long, and I would go closer to the within 12 hours to be getting that enteral nutrition if they're not able to eat orally. Okay, that's all I have for nutrition. I'll take it back to Mary.
Thank you, Becky. Nutrition is just so important, which is why you may be asking, why is a nutritionist on this panel? And truly, nutrition is so important. Nutrition and hydration are so important for individuals with SMA, especially during illness. My next speaker is Dr. Richard Kravitz. He is a professor of pediatrics, Division of Pediatric Pulmonary and Sleep Medicine at Duke University School of Medicine. Dr. Kravitz.
Thank you, Mary, and thank you to all the attendees for taking time out of your busy day to come and hear what we are very passionate about caring for as our patients with spinal muscular atrophy. What I'm going to talk about over the next 10 minutes is their basic respiratory health care, both while well, sick, and special considerations that one needs to do for the COVID-19 pandemic. So the key thing is we're all focusing on COVID-19, how it impacts us, how when we're sick, but these children and young adults have special needs, and they need to maintain their regular respiratory care even when they're not sick. So we have a treatment protocol that's individualized for each patient. So if they're doing airway clearance, even if they're not sick, they need to maintain their usual airway clearance regimen. This is usually with a piece of equipment called the cough assist. Some patients might have a therapy vest or do manual chest PT, but they should continue it on a regular basis. Even with COVID-19 around, they don't need to increase their treatments if they're otherwise well. If they have nighttime ventilatory support, such as BiPAP or non-invasive ventilation, or some of our patients are on have a tracheostomy and mechanical ventilator, they need to maintain their baseline settings. So in other words, if they're using their treatments just at night, when they're well, they can maintain it just at night. Becky did a great job talking about diet and hydration, and we want our kids to make sure that they're eating well and drinking well. And so we want to basically maintain their usual home regimen while they're well. With the COVID-19 pandemic, what we're adding into their well child care, so to speak, is the practice of social distancing and other CDC-related COVID-19 guidelines. And these can be easily found online. The special aspect of social distancing is many of our families have helpers that come in, whether they be visiting nurses, respiratory therapists, physical therapists, occupational therapists. A lot of care is done in the home. And we would remind our providers and our families that these patients could be potentially sick. So before anyone comes into the house, families screen them to make sure that they're not been sick recently, that they have no fever, that they're not at risk for COVID-19. So again, we practice social distancing, and we just want to screen not just family members, but any guests. We'd also recommend that play dates be put on hold for our patients at this time. It's a lot of common sense medicine, but it always needs to be reminded. Next slide, please. So what happens when our kids get sick? Well, pretty much all our kids have a sick protocol that they institute when they get ill. Now, we are having kids with SMA get sick now, but it's with the usual springtime viruses that we otherwise always see. And so far, to the best of our knowledge, there haven't been any reports of patients with SMA coming down with COVID-19. So our parents need to be reminded, and you need to remind them to do their sick protocols when they get sick, whether or not it is COVID-19. This will include increased airway clearance, such as taking the cough assist and using it instead of maybe their once or twice a day baseline to more often, up to every 3 to 4 hours, or frankly, as often as they need it to keep good airway clearance and get rid of secretions. Patients who are using non-invasive ventilation should continue to use it as they usually use it, but when they're getting sick, sometimes they need more support. That may be including using it during the daytime. And also, if they have a ventilator where they have secondary settings, a lot of our families might have patients with their kids have one setting when they're well and another setting when they're sick. Remember to switch them over to their sick settings, which usually gives them more support until they're better. Again, as Becky said, we want to maintain good hydration and appropriate hydration. When they're coughing more, when they have a fever, they're going to have increased insensible losses, and water intake or fluid intake will need to be adjusted accordingly. We also want to make sure that they have good fever control. The fevers can make the kids uncomfortable. It can also increase insensible losses. There's a lot of questioning going on right now for fever control in the era of COVID-19. Should we use Tylenol versus Motrin? There's some anecdotal evidence, or some anecdotal experience suggesting maybe ibuprofen should not be used because it might increase the risk of catching COVID-19. There's no proof of that at this time, so I feel that we can safely recommend ibuprofen or Tylenol, though some families may be more preferential to going to acetaminophen. I would defer this to your practice's plan and the family's comfort level. Next slide, please. We want to maintain close monitoring of their oxygen saturations. Most of our families have pulse oximeters. If they don't have one at this time, it means they probably don't need one. But if they feel more comfortable, they can be bought at a local pharmacy for a small price. And we monitor their saturations. And when they're sick, they need to be monitored more often, both while awake and asleep. And if their oxygen saturations start dipping below their baseline, which is usually 95 or greater, it implies that they need more respiratory support. This usually will manifest as more cough-assisted treatments and or more ventilatory support. The families need to keep your practice as well as their SMA team advised as how they're doing. As the primary care providers, you are our boots on the ground. A lot of families will be able to come in and see you in your practice. You need to be aware of what their sick protocol is so you can monitor them and determine if you can manage this at home versus your office versus having to send the child to the emergency room. One warning sign that they might need to be seen in the emergency room is if their saturations are dipping, they're doing more airway clearance and more ventilatory support, and they still cannot maintain normal oxygen saturations. That would be a sign that they need more urgent assessment. And again, as before, continue monitor following the CDC guidelines. Next slide, please. Okay, so what actually happens if they get COVID-19? How does that change things? Well, in regards to their acute management, it doesn't change anything. COVID-19, at the end of the day, is just another virus. It's a pretty serious virus and is spreading like wildfire. But how it impacts on SMA, it does not appear to be, we just don't have enough data to say if kids with SMA respond differently. So for now, we maintain the same diligent sick care protocol that I previously described. Where we do get into a bit of new ground is that a lot of our airway clearance equipment, the cough assist, nebulizers, BiPAP, non-invasive ventilation, can generate increased aerosol production, and this aerosol can be filled with COVID particles and be at risk for infecting caregivers, the parents, grandparents, siblings, and visiting nurses and therapists. So we still recommend doing usual CDC guidelines, but extra precautions have to be put in. This would be probably a prudent time for the caregivers to be wearing a mask, to potentially wearing protective garb if they have a gown or just some type of covering, or changing their clothes after they've done a respiratory treatment to try and keep the virus from spreading. Wearing gloves, especially when cleaning the equipment between use, would also be very important. So we want to make sure not just that our child with COVID-19 is getting the care they need, but the caregivers and your office practice is not being put at increased risk. Many primary care practitioners have an internal protocol for if they see patients that are suspected of having COVID-19 or patients that actually are infected. We recommend using that protocol for your SMA patients. Next slide, please. Okay, so what happens if the patient needs to go to the hospital? Well, obviously, we want you guys to be keeping close tabs with your families when they're sick. If you judge that they need to be seen in the emergency room, it certainly is wise to send them there. I would recommend that you call in advance to let the ER know that they're coming, and that would be whether they had COVID-19 or not, but certainly the ER staff will appreciate a heads up if you know that they're COVID-19 positive. Review with the attending of the day what special SMA protocols may need to be put in place. Our families are outstanding advocates for their child's care, but we can help them along. An advanced phone call to the ER physician is always well received. I always encourage the families to bring their equipment with them to the emergency room or to the primary care doctor's office when they're sick. That way, if they need to do treatments while there, they have their equipment. I always encourage the families to make sure that the equipment's labeled with their name and contact information, just so it's well identified. Especially nowadays with potential shortages of ventilators and the like, if a family is on a ventilator or has a BiPAP machine, having it with them will be reassuring, so they will be able to get the care they need and not be dependent on a hospital ventilator. Next slide, please. Remember, whether the child presents to your office or you refer them to the ER, that many times the presentation symptom of illness will be hypoxia. Do not treat that with supplemental oxygen alone. If they are hypoxic, it's usually due to ventilatory perfusion mismatch from mucus buildup and they need airway clearance, or they have they're hypoventilating more and need more ventilatory support. Supplemental oxygen is acceptable in the context of adding in more airway clearance and increased ventilatory support along with close monitoring. Remember, our families are great advocates for their child's care, but we can add voices to the choir and make sure that they get the care that they need. Maintaining close contact with the ER staff and the inpatient hospital team, if they're admitted, goes a long way. And please, if you're working and doing all this on your own, kudos to you, but please let the SMA care team back home know what's going on so we can help out too. Anyway, that's it for now. Rob Graham's going to pick up and talk more about the inpatient management, and I pass the mic back to Mary.
Thank you, Dr. Kravitz. Thank you for the pulmonary review. That was great. My next speaker is Dr. Robert Graham. He is a senior associate in critical care medicine, Department of Anesthesiology, critical care and pain medicine, associate professor of anesthesia, Harvard Medical School at Boston Children's Hospital. And as Dr. Kravitz indicated, Dr. Graham will pick up where he left off. Thank you, Dr. Graham.
Thank you, Mary, and truly want to thank everyone for attending. And I'm going to pick up and sort of reiterate some of the things that Dr. Bakri and Ms. Hurst and Dr. Kravitz have actually already spoken to, and talk about the inpatient sort of acute care needs. So I would like to start with sort of helping families navigate home care briefly. As Dr. Kravitz mentioned, this is challenging, and as their providers in the community, one of the things that we also have to recognize is there's a lot of fear out there currently, not unjustified, but certainly something to acknowledge and realize that families may be calling you about one thing, but in the back of their minds, they are thinking about COVID at all times. They also may be considering, they may have extra care needs at this point, or care burden, as they may not be able to utilize their normal personal care assistants or normal home nursing, partially out of their own sort of self-quarantining, measures, but also because of the lack of availability. There's a reduction in this in the sense that some nurses are, contracting their panels and saying, that they'll serve one family and not three, and a number of other sort of measures that are being put in place. So families may be overextending themselves, and that individuals, whether they're children with SMA or adults with SMA, may not be, or may be struggling with sort of their routine care. So just to appreciate that. I'd also, as we sort of think about, and Dr. Bakri mentioned it, and I think Dr. Kravitz as well, is, the question of desire or lack of desire to come to a hospital or a clinic. One of the things to emphasize is that we have to establish some thresholds, taking into account, the desire to minimize exposure, but also not to wait too long when something that could be managed becomes more emergent, and that we don't want to accumulate morbidities. And that's obviously going to be a case by case, but something to sort of work with families around. What's the risk benefit of staying at home for anything? So along those lines, Spinraza and Zolgensma provision, the questions have come up, and hospitals are determining what is considered elective versus emergent or semi-urgent. I think all of us would consider that Spinraza provision, and certainly Zolgensma for those who qualify if they're newly diagnosed, are not elective. And one of the things as providers is you can actually help advocate for that, because the hospitals are looking for some guidance and relying on the primary providers and primary teams or SMA teams to say, no, in fact, this needs to move forward. And that most hospitals have contingencies in place to help with that, to, as I think Dr. Bakri said, facilitate, sort of means of getting in with minimizing exposure to direct treatment rooms and otherwise. And some will actually have some screening for either symptomology or actually testing now that it's slightly more available in advance. Partially to minimize sort of exposure for the patient, but also to protect healthcare workers and make sure that we have a workforce in place. So we would consider those urgent and non-elective. Along those lines, also things that have come up and we've been navigating with families, things such as placement of gastrostomy tubes, that maintenance of an NG tube at home for those who are sort of having swallowing dysfunction and otherwise, that we would probably consider placement of a gastrostomy tube non-elective, that the risk of maintaining this at home with aspiration or misplacement of the tube and otherwise, something to think about, and again, work with on a hospital and case-by-case basis. Now, the inpatient management, and this is a much bigger topic, really, this is where I think a lot of fear is being generated from, and also the uncertainties. So I think it's, and Dr. Schroth mentioned this and others, that we don't have a sense that the SMA population is any more vulnerable from an immune standpoint or otherwise, but I think all of us are cognizant of the fact that, yes, any respiratory illness, they're at high risk for having complications. There really aren't, we haven't, internationally, there haven't been reports of SMA affected individuals in particular. And, certainly as we look at the age range, we do have some older individuals with SMA who may have other comorbidities that are non-SMA related that may put them at higher risk. But it is something that we just don't, there's not enough data at this point. Nevertheless, I think it's helpful to also realize that, the question is, where do people go? Where should they present if they're having an acute issue? Well, the vast majority of our patients are not going to be COVID positive, but what we are seeing is contraction of care sites as adult facilities, or those who provide adult and pediatric facilities in the same acute setting are actually appropriating pediatric beds, pediatric ICU and floor beds, and even NICU beds for provision of adults who are disproportionately affected. So what the Children's Hospital Association has committed to is that each region and perhaps each state will have either freestanding children's hospital or a designated pediatric facility for which children should be referred. Now the question is, we do have young adults or even older adults who with SMA who are cared for primarily at children's hospitals, there are no current triaging recommendations against that, and we would actually recommend that they go to their primary sites. It is worth recognizing that the crisis standards of care are being implemented differently from state to state. There are usually carve-outs for pediatric conditions, but a lot of states are still, or a handful of states are still referencing SMA as a non-curable progressive condition, which are out of date, and during previous public health considerations, they were actually screened out and triaged in adult conditions. So it's something to sort of look to your local regulatory bodies, Department of Public Health and otherwise, to see what their status is with regards to that, and try to advocate for your families. As Dr. Kravitz said, once patients are coming in, we recommend that they bring in their equipment. That is theirs. There are rumors that equipment is being taken away from patients. In fact, that is not true. That's not allowed. And so they should bring theirs in with the assumption that they can use it. And a lot of hospitals are opening up their allowances for that, whereas oftentimes they do ask that they only use hospital equipment. Screening and actually visitation have been highly variable depending on the hospital and availability of testing. So families may find that only one parent can visit or one care provider, and then they may actually recommend screening both the affected individual as well as their whoever's accompanying them. But again, that varies from place to place, and also how they implement precautions. Again, as we look at screening in the younger patients, actually, although even in symptomatic patients, the vast majority are screening out for COVID-19. I think as Dr. Kravitz says, we are still encountering our routine spring viruses and still residual from our standard winter viral processes. So at a lot of the hospitals that are keeping track, over 90+%, actually, I think over 95% of pediatric cases in general are screening out even when symptomatic, with the presence of other viruses being flu, residual RSV cases, and a variety of things, including human metapneumovirus and others. So families will find that sometimes BiPAP, I think as Dr. Kravitz said, is being implemented differently. They should bring their own interfaces, but due to if they're ruling out or if they are COVID positive, a lot of places are trying not to utilize BiPAP. If they are, they're using full face mask with additional filters to minimize aerosolization and risk to actually everyone else in the hospital. And in many of the adult ICU settings, they are not using non-invasive support at all. Rather, if you have a certain degree of oxygen requirement, they are actually moving straight to intubation, partially because of the trajectory of the disease is so rapid and severe, but also, again, to minimize the risk of aerosolization. Families will ask, and you can ask about various protocols. There is currently no treatment. The hydroxychloroquine, antivirals, azithromycin, all of these are under investigation, and various hospitals have protocols of which they're under research strategies right now. I think we will have a lot that will sort of emerge, but not likely in the short term. And that we'll learn a lot going forward, but not to anticipate that they will receive a specific treatment when they arrive. Similarly, the standard management, if they are COVID positive and this is an evolving respiratory failure, it is a combination of standard ARDS management, as we're seeing in the adult population. And then for the SMA group in particular, it's implementation of a neuromuscular protocol with augmented secretion clearance, and as Dr. Kravitz alluded to, using positive pressure and these measures in conjunction with oxygen supplementation, not just standard oxygen supplementation. There are other things that we're learning as we go along in the critical care community in terms of these. The COVID positive patients seem to be prothrombotic. A lot of them require renal replacement therapy, and there's evidence of pulmonary vascular changes. I think, again, this will not be SMA specific or SMA protective, but probably reflects something intrinsic about the virus and the immune response. And I think we'll be learning more as we go along. So again, I'll wrap up and want to make sure we leave time for some questions. I think one of the challenges in the SMA community is, as we've said, that we represent sort of the age spectrum, and I think as we look at our older patients with SMA, the access to adult hospitals may become increasingly challenging, and then the access for pediatric patients will not necessarily be COVID directly related, but rather indirectly, as there's consolidation of pediatric care, and that all appendicitis, all gastroenteritis, all pneumonias, and all pediatric traumas will be consolidated into fewer and fewer facilities as those fill up with adults, and hence we can be prepared for capacity issues, not because of COVID directly, but indirectly. So I'll finish there and hand back off to Mary. And again, happy that Cure SMA is sponsoring this, and always look to us as a resource.
Thank you, Dr. Graham. Thank you so much. We would like to now start the Q&A session, where we will answer some of the questions that you have submitted. As a reminder, you can ask additional questions now. And you can submit these questions via the GoToWebinar chat box on your screen to your right, or in your follow-up survey. Next slide. How can we best help people with SMA and their families via telehealth? I'm going to ask each of the panelists to give some input about their experience with telehealth, and I'm going to start with Dr. El-Sheikh. You may be muted, Dr. El-Sheikh.
Thank you, Mary. The goal is to continue to provide access to the multidisciplinary care team using telehealth as possible. Definitely, as mentioned by Richard and Rob before, this is going to help address several things. It will help address also the regular clinical care needs, medication refills, and also will help avoid unnecessary visits to urgent care or to the emergency room. Other services such as physical therapy assessments and advice on a home exercise program, nutrition advice can also be provided using telehealth. Perhaps one of the things I would like to mention about availability of internet access to the patients and the families. There is a federal program that lowered the monthly cost of phone or internet services for those who qualify. That's a lifeline program for low-income consumers, and probably should make a note of that.
Thank you. Go ahead.
No, I just wanted to say back to you, Mary.
Thank you, Dr. El-Sheikh. Becky?
Yes, so we provide telehealth opportunities in our area. What we found has been the most successful, and I don't know if we have found, at least for nutrition, that it's helpful for us to not just have audio, but to have visual, so we can actually lay eyes on the person who we are assessing. We have also instituted some, we're actually working on a video, but we have a little handout that instructs people, parents of children with SMA, how to get weights at home and how to get lengths at home, as well as how to do a mid-arm circumference at home. We have had success also at our facility. We have 3 different audio-visual capabilities that we have tried. We've tried WebEx, FaceTime, and Google Duo, and all with success. There are limitations to all of them, so I think it's best to just investigate in your area. The limitation with FaceTime is that both users have to have an iPhone. But there are also various other modalities. What we have also found is that our insurance providers in our areas have asked us to provide a line in our assessments. after these telehealth visits, just saying that the visit was performed, with audio and visual capabilities during the COVID pandemic. Back to you, Mary.
Thank you, Becky. Dr. Kravitz?
Yeah, here at Duke, we are offering telemedicine. We've been offering telephone phone calls for all our families, and from a video perspective, we've been really ramped up over the last week or so. So all our families are having their visits converted to virtual visits, and then we provide them with whatever they request. The entire SMA team is available to them at the time of their regularly scheduled appointment. So if they have any questions of pulmonary, nutrition, neurology, nursing, social worker, OT or PT, they're all available that day to discuss things and answer their questions. And we triage them to see whether or not they need to actually be seen if any healthcare concerns are raised. But we're offering the telemedicine. As Becky just said, you can use FaceTime if both people have an iPhone. That's just temporary waiving a HIPAA or regulations. That's not expected to be a long-term option for us, but we are offering it, and we are there for our families. Okay, Mary.
Great, thank you, Dr. Kravitz. Dr. Graham?
Yeah, we've certainly, with our home ventilation program, expanded our telemedicine presence. I think it's been very helpful, especially in the rural areas where, at face value, it makes sense at the outset. But we are continuing to offer in-person home visits for the select few that are transitioning to new devices. So if they're being discharged from the hospital on a new vent or on a new BiPAP or otherwise, and I think this is at the preference of the family and for community providers to think about this. It's the highest risk time for transition. And so, while telemedicine does offer a lot of advantages, there are certain things that when we think about risk patients that you might want to consider and weigh the risk benefit. Along the telehealth line, though, one of the questions comes up if one of our patients or families are hospitalized and not at their primary institution. I think everyone has made the commitment to have their healthcare providers reach out to those institutions and help, and either teleconference in between providers. I would highly recommend that. There may not be a capacity to repatriate someone for a while. And so I think it'll be helpful for those providers who aren't as familiar with SMA, perhaps, and certainly for the families to use that technology, which is readily available as well.
Great, thank you, Dr. Graham. We are almost at 3:30. For those who need to drop off, thank you for joining us. We will keep going with additional questions, and you are welcome to stay on. Next slide, please. Our next question is, will COVID-19 positive patients with SMA receive treatment for COVID-19? Dr. Graham?
Yeah, so, this is, as I sort of alluded to, the crisis standards of care. Currently, if there are no capacity issues or otherwise, that there is no sort of triaging or otherwise. New York is our most city and state at this point. I think we can expect surges to happen, but at the current time, most hospitals have surge capacity. Surge capacity, and that patients with SMA would not be triaged out. That said, as I alluded to, that each state is actually handling this and actually imposing upon healthcare institutions a set of guidelines, and you should, if you have a child or family or an adult, more importantly with SMA, is to try to find through the DPH what those crisis standards of care, what constitutes them, because in fact, actually, as I said, many of these are outdated with regards to what status of SMA. And we don't have any reason to believe that SMA patients would have a worse outcome than any other population.
Thank you, Dr. Graham. And I just want to add to that Cure SMA reached out to governors of all the states regarding the outdated policies regarding emergency resource allocation, because we were notified that there are many policies that are out of date and discriminatory. And we requested that states take a look at those. And so I also ask you as providers to take a look at your emergency triage and whether you're excluding populations that should be reevaluated, including spinal muscular atrophy. Thank you. Next question. What are the current recommendations for scheduling maintenance doses of Spinraza during COVID-19? Dr. Al-Sheikh?
Thank you, Mary. Yeah, so as we talked about earlier, the goal is really to deliver treatment on time. However, if a dose is missed, for instance, if a loading dose is delayed or missed, nusinersen should be administered as soon as possible with at least 14 days between doses and continue the usual schedule thereafter. Similarly, if a maintenance dose is delayed or missed, again, it should be administered as soon as possible and a catch up with the doses or the routine schedule thereafter.
Great, thank you. Thank you. Next question.
Mary, I might add on to that.
Oh, please.
Yeah, I might add on to that in general, we also have to consider the backlog of elective procedures that are coming. So, you know, having a dose now means that you don't have to, as sort of the hospitals and everyone emerges from this, that we anticipate that there are literally going to be hundreds and hundreds of procedures that are backlogged. So families can consider that as well.
Great, thank you. I also want to point people back to our website. If you go to our homepage and then click on the COVID Resource Center, we have a number of documents there to support activities. If there are things that you would like Cure SMA to address, or you think it would be helpful for us to speak up about a particular issue, please email me, mary@curesma.org. Next question, please. COVID-19 appears to present as asymptomatic or with mild symptoms in the general pediatric population. Considering this, would we expect more difficulty in people with SMA compared to usual presentations of viral start infections? Dr. Kravitz?
Well, that's a really good question, and I wish we had an answer. We just don't know. That being said, every child with or young adult with SMA responds to viruses differently. So it's really important that they take any infection, even if the symptoms are mild, seriously, and increase their airway clearance. So even if they have a mild cold with a little bit of increased cough and congestion, increasing airway clearance, making sure they use their nighttime support if they're on it, is key to good overall health.
Thank you. Any other panelists wish to contribute? Thank you. Next question, please. What are your recommendations regarding immunizations during COVID-19? Who would like to take this one?
Well, speaking as a general pediatrician, as well as a lung specialist, every child should get their immunizations, and the COVID-19 is not an excuse not to get it. Again, most primary care doctors, as I understand it, kind of have a nice triage system for well children versus sick children. And this is a well child care aspect. They should be able to be seen in clinic, in the practice, get their shots and get out without too much difficulty. So I would not put immunizations on hold. It's a little late in the season for the flu shot now, but if they're due for a pneumovax, I would certainly encourage them to get the pneumococcal vaccination.
Thank you. Anything to add? Okay, next question, please. Have there been any cases of people with SMA being infected with COVID-19 in the U.S.? I can share one situation that we are aware of, and that is a young adult with SMA, and their caregivers developed the symptoms of sudden onset of loss of taste and smell. and had mild symptoms, and they recovered very well at home. But the loss of smell and taste was very disturbing. And that's the one case that has been reported to me. Any of the panelists have any experience or hear of other cases?
Now, I haven't heard of it. This is Rob Graham again. I haven't heard of any SMA-specific cases, but I think we also have to assume, given the lack of screening and testing in the general community, as well as just knowledge of the prevalence in the, our understanding of the prevalence is that there are probably some who are asymptomatic or feel that they have mild illnesses, just given the lack of tracking and tracing of active cases.
Thank you. Any other comments?
I agree with Rob. There is no published cases out there, and probably again mild cases might get missed if they did not get testing.
So I want the audience to know that Cure SMA, as part of the COVID support package, we are asking families to answer questions about their experience with COVID. So please encourage them to go to our website, request the support package, and answer a few questions. Thank you. Next question. Or that may be the last one. Yes. So I want to thank you all for your time today. Cure SMA wants so much to be a resource for you during these difficult times. We will post this video on the Cure SMA YouTube page in the next couple of days. Please visit our webpage, www.curesma.org, for any updated news regarding our events and services. Thank you so much and have a wonderful rest of your week.